One of the most frequent questions that we get as we're starting up sites in the National Cardiogenic Shock Initiative is, when should we consider escalation, and what are the early predictors that a patient may need escalation? So when we look at the 65 patients included in the National Cardiogenic Shock Initiative to date, predictors of survival are centered around two main focuses: the overall lactate level and the overall cardiac power output. If your patient is able to decrease their lactate level to less than 3 and maintain a cardiac power output greater than 0.8, their overall chance of survival is very high. In our cohort, it was 95%. If, however, your lactate levels remain elevated, greater than 3, and your cardiac power output remains low, less than 0.8 watts, your chances of survival are very low. In our cohort, it was 36%. This is the group of patients who you need to consider for possible escalation. Clearly, when we talk about escalation, it's a time to bring in families and a multidisciplinary approach, because it involves many extra facets compared to the acute setting of AMI and cardiogenic shock, which we deal with regularly in the cath lab. In these patients, we need to make sure that they're viable candidates and possibly candidates for advanced heart failure therapies such as durable LVADs and even heart transplants, and their overall chances of recovery. If any of these are not met, and if the chances of recovery are low, this is the time to talk about palliative care and possibly hospice options as well. If, however, you are a candidate for these advanced therapies, or if there is a chance of recovery according to the heart team, then escalation of therapy is warranted. In the National Cardiogenic Shock Initiative, we've never been very specific on the scale of escalation or the types of devices used for escalation, because we feel that it's a very institutional specific approach based on what the multidisciplinary team is available to have in terms of devices and in terms of local expertise and practice patterns. However, today what we'll share is the algorithm and the approach we use at Henry Ford Hospital, in the hope that it may help those who are still formulating therapies or protocols for escalation. So at Henry Ford Hospital, when you have a patient who comes in cardiogenic shock, we look at three main parameters, similar to the National Cardiogenic Shock Initiative algorithm. We look at cardiac power output, we look at pulmonary artery pulsatility index, and we look at the cardiac output deficit. And that's a simple calculation to be able to help in decision making with escalation. So it's your target cardiac output minus your actual cardiac output. Your target cardiac output is calculated as 2.2 multiplied by your body surface area, and your actual cardiac output is that what you measure on your right heart catheterization, likely using the Fick equation. So when we look at these parameters, we're able to put together a full picture of what the patient is going through. So clearly, medical therapy is an option in certain patients. So cardiac power outputs that are greater than 0.8 and PAPIs that are greater than 1, these patients could potentially be treated with medical therapy, particularly those patients who have advanced chronic heart failure and may do well with inotropic therapy. These patients also may do well with a little bit of augmentation of afterload and intra-aortic balloon pump. And in the event that they are having end organ dysfunction, an Impella CP may be used. If you go to the next category, patients with cardiac power outputs greater than 0.8 but PAPIs less than 1.0, this usually indicates patients with right ventricular failure. These patients can be considered for right ventricular support, whether that's in the form of a Protect Duo tandem heart right ventricular support device or an Impella RP support device as well. So when you have a cardiac power output less than 0.8, however, then you really need to consider why the patient is not able to perfuse themselves and whether this is an isolated left ventricular problem or a biventricular problem. In patients with biventricular failure, a conscious decision needs to be made based on the cardiac output deficit. If these patients have a large deficit, which we've defined as greater than 4 liters, then these patients should be considered for a more advanced form of hemodynamic support, whether that's an Impella 5.0 with a possible right-sided device if needed, or whether it's a combination approach with a biatrial tandem heart, or if they need an ECPella system where an ECMO and an Impella are placed at the same time. If, however, these patients have a predominantly left-sided problem, then we typically start with either an Impella CP or a tandem heart. The most important decision after the placement of the initial hemodynamic support is to repeat the hemodynamics and keep a close eye on patients with a high suspicion of needing further escalation. So that's when we come to the second tier of repeating hemodynamics and looking for outcomes. So patients at high likelihood for needing further escalation, our practice is to wait 15 minutes in the cath lab and repeat hemodynamics. If the hemodynamics are worse or not consistent with the improvement we would expect in a short duration of time, we consider early escalation. If we need more time, which happens in many patients, then we send them back to the ICU and repeat hemodynamics in 30-minute, 1-hour, or 4-hour intervals based on the patient's condition. In this scenario, if your cardiac power output is maintained greater than 0.8 and a PAPI greater than 1, then we're considered to be sufficient on the current level of therapy that we're on. If the PAPI drops to being less than 1, we can consider inotropic therapy at low doses or consider putting an isolated right ventricular support device in. If, however, patients continue with biventricular failure, a higher level of support is needed. That could be escalating to an ECPella system, as previously mentioned. And in patients with isolated left ventricular failure, consideration of devices such as a Centramag or a durable LVAD should be made in a multidisciplinary approach. So this is our protocol at Henry Ford Hospital, using the devices that we have within our institution and our local practice, and we encourage all of the national sites to be able to look to the devices that they have in their laboratories and their local expertise to be able to make a protocol that is well suited for your institution and your local practice.